All right. Well, it says that I'm live, so I guess I have to take its word for it. Hi, everyone who's here. Looks like a few people are here already. So happy to see you. Thanks for joining, Noel, and glad you're excited to be here. I'm excited to be here too, although I honestly don't know what to expect. Um, I'm kind of wondering if, hi, Riverly. Um, Hey, the Mastermind 01. Thanks for joining. Yeah, I'm kind of wondering what attendance will be like today. It is after all a Friday afternoon. Hi T Wills. Hi T Tan. Thanks for joining, everyone. Anyway, I'm Dr. Mark Ettensohn. I'm a licensed psychologist with an somewhat unusual specialty. My clinical specialty is working with pathological narcissism and NPD. I'm here to answer questions and talk all things narcissism. So let's have at it. I'm wondering if anybody has any questions to start off. Hi, BD Wilson Neal. Yeah, thanks for being here. So let's see. T Wills. How do feelings switch off for someone we once deeply felt for? Is this attachment theory related or specific to narcissism, and is there a difference? So I guess I imagine what you're talking about here is the kind of fluctuation in the intensity of feelings for some people who have a narcissistic personality configuration where when there's a breakup or a separation of some kind, it's almost like the love object is just you just kind of don't like, they just kind of cease to be a factor in some way. And I've heard a number of patients that I work with discuss this phenomenon as well. As far as how that actually happens, I'd be hard pressed to, I think, come up with a specific mechanism. And I'd kind of just be hypothesizing here. I think you're probably onto something when you discuss attachment. Most, if not all, of the patients with whom I've worked that I would say had a narcissistic issue of some kind or another, they had a significant they had significant attachment avoidance. And so, if you may have seen this if you watched my most recent video, but essentially human attachment comes down to two dimensions, right? There's the dimension of attachment avoidance, and then there's the dimension of attachment anxiety. And I'm kind of going like this, not because I'm intending to bless the screen, but because that configuration is typically conceptualized using a chart with an X and a Y axis, where the X-axis is attachment avoidance and the Y-axis is attachment anxiety. When we're thinking about attachment avoidance, we can also call that sort of an internal working model of other people. And oftentimes when somebody has experienced certain kinds of abuse or emotional neglect when they were very young and throughout their growing years, as well as some peer rejection sometimes, they can be high in attachment avoidance. And that's because their internal working model of other people tends to be negative, right? So they've experienced a lot of disappointment, a lot of frustration, a lot of heartache with respect to their primary caregivers and other attachment figures in their lives. And so they therefore have kind of internalized this negative or distrustful model of other people. And really what that ends up causing over time is it sort of interferes with a person's ability to really feel their love for someone else. It makes it difficult to be vulnerable with other people. And it tends to kind of turn the volume down on the various dependency longings and the feelings of longing for attachment and close relationships that other people might experience. And so another thing that can happen with high levels of attachment avoidance is that the person tends to get really good at just kind of not paying attention to their feelings. And that's something that you even see in childhood attachment studies, where they're like observing the child, and they have this situation called the strange situation, where the caregiver and the child are together in a room, and the researchers watch them interact for a while, and then suddenly the caregiver gets up and leaves the room, and the caregivers watch how the child reacts to the sudden absence of the caregiver when the child is in this strange situation. And children who are high in avoidance, they tend to not react to the absence of the caregiver. They tend to focus in on neutral stimuli, a toy that they're playing with, or whatever. But if you take like physiological readings of the child, like monitor their blood pressure or their heart rate or something like that, you see that they are actually distressed. They're just learning to disconnect from that feeling of distress. They're learning not to represent that distress to themselves, and they're learning not to express it. And so I think something like that happens when there's a breakup or there's a loss of some kind for somebody who's high in narcissism. They tend to default back to that kind of avoidant attachment coping strategy, where they just don't think about it. And that's one way that that can kind of play out. So I hope that answers your question. I guess, and at the end of the day, my answer would be yes. I think that does relate to underlying attachment dimensions. And I don't think it's specific to narcissism. I've seen it in other personality configurations as well. I think that's about attachment avoidance. So thank you, T. Wills, for the question. What else? I always feel like I'm in the hot seat when I'm doing this. It's a bit of a rush, but it's also kind of nerve-wracking. So apologize if it takes me a few minutes to kind of get into the swing here. Okay, so Narcissist Hex. I was just wondering if you have any opinion on a cure for NPD, or if it's like a condition like diabetes where you just manage it. Well, as I've said in other videos and podcasts and stuff, in mental health, we don't really think about things in terms of cures. And that's because we don't really understand the underlying mechanisms that presumably are responsible for the psychopathology, right? And in fact, even when it comes to sort of defining the psychopathology, that's something that's typically, decided by committee, more or less. The American Psychiatric Association, I'm referencing the DSM up there, gets together, on a fairly regular basis, and they have meetings where they review the evidence and the most recent research, as well as probably some other political considerations that they have, and they draw new lines around disorders, right? We're going to take this criteria out of this disorder, and we're going to add this criteria to this disorder. We're going to change, the duration of symptoms, to qualify for the disorder. We're going to add this new disorder, et cetera. And that's because we don't really have like a biological basis, as a foundation, right? Validating these constructs, so we don't have like a lab test. You can't draw blood and be like, aha, you've got, such and such levels of depression, right? It's not like in the Phantom Menace, right, where they're like measuring how much force somebody has by their midichlorian levels. It's not like that in mental health, and so we don't really, because we can't conceptualize it in that kind of a concrete way, we can't really talk about cure, because while the symptoms may remit, and there may be substantial improvement in the person's life, since we really didn't know what caused the problem to begin with, we can't really say, well, now you're cured. We can just say, well, now you're doing better, right? Or now you don't qualify for this disorder anymore, or something like that. And so, I really don't tend to conceptualize mental illness in a biological way. And so, and that might just be my bias as a psychologist too, right? I'm trained in psychology, so I think about things psychologically, and not so much neurologically and that sort of thing, not so much medically. So when it comes to comparing something like NPD to something like diabetes, that's the first disconnect for me. Is, diabetes is a very well understood physiological condition, whereas NPD is a not very well understood psychological condition. And even experts on NPD, they won't necessarily agree on the core or essential features of NPD. There are, like, for instance, I've made a number of videos about my disagreements with the DSM model of NPD. So anyway, that's kind of like the context. Okay, that's the frame I'm trying to draw around my answer here, which is, I guess it really just depends on the person, on their situation, and on the specific kind of configuration of NPD or pathological narcissism with which they're presenting. For some people, I would say that, yeah, this is, it's a chronic condition, and you're doing your best to manage it. And for other people, there might be a fairly quick, or even it might take longer, but there can be remission, right? And that's, again, even the term remission is a little bit problematic, because the way that I conceptualize these issues is really kind of like a developmental model. It's a developmental trauma that interrupts the development of whole object relationships of a complex and nuanced and realistic and stable model of self and other people. And because of those issues, the person ends up having to rely on maladaptive coping strategies to deal with all the slings and arrows that, life throws at them. And then those maladaptive coping strategies beget, more trauma and more issues, which the person internalizes in the form of more wounds to the self, et cetera. And so if you can help the person begin to step outside of that, kind of cycle of destabilizing responses to experience, and then at the same time be providing them with some of the materials in the form of, validating self-object experiences and the experience of empathy, and kind of a reparative experience of being sort of seen and mirrored and understood, then to my mind, the self begins to heal. And so I wouldn't really even think of symptoms remitting at that point. I would think of the person developing past the place where they would need to be relying on some of those maladaptive coping strategies. Anyway, I don't know if that answers your question, Narcissist X. I might have just opened up, 12 other cans of worms in the course of trying to answer it. But I guess what I'm trying to say is it's not so cut and dry as just, can we cure this or not? Everybody's different, and really, I see this. I chose the word Heal NP, the name Heal NPD, for a reason, because I see this as a wound that needs to heal, and that's my perspective on it. So I don't know if that answers your question or not, but thanks so much for asking it. What else? Okay, T-Tan, do I understand correctly that you like to use psychoanalytic and dynamic approaches? What made you decide to stray from more common schools of therapy, and how did it show in results of healing patients? You do understand that correctly, yeah. So I'm a psychoanalytic psychotherapist. I'm not a psychoanalyst, because that is a whole other echelon of training. Essentially, psychoanalysts have a doctorate on top of their original license eligible degree. So, and I don't have that, but I have spent a lot of time researching and reading and participating in case consultation groups. And I was on the board of directors for a local psychoanalytic association for a number of years. And I currently teach psychoanalytic concepts and interventions to doctoral students. So I fairly well versed in the various models in the psychoanalytic tradition. So what made me decide to choose that? Well, it just always spoke to me. I feel like, and there's another, I think he's a psychologist out there named Jonathan Shedler, and he's an advocate for, kind of, well, he's an advocate for psychodynamic approaches, really. And one of the things that he talks about in a presentation, and I think you can find it online somewhere, is the tendency toward these kind of what are called manualized therapies. And he describes therapists sort of becoming technicians, right? Instead of clinicians, they're becoming technicians. Someone who opens up the book, opens up the manual, and then applies the the intervention, right? Whatever the manual says the intervention ought to be. And the problem here is that psychotherapy is really both a science and an art, right? And the art piece of it has to do with, and I feel like that's in some ways the essential piece of it, which is the ability to sit with human suffering and to try despite whatever odds might be present either for or against, but to try to connect with that person on a human level. Because I feel like a lot of the things that cause the car to go off the rails when it comes to human psychology has to do with ways that people have just been damaged or hurt or wounded or abused or traumatized in the context of human relationships. And so I see psychotherapy as fundamentally a reparative process that is relational. And so, a lot of the kind of what you're describing as more common schools of therapy, they're really about, okay, we've got a circumscribed disorder here, right? And now we've got a manualized treatment to apply to this disorder. And that's a very medicalized way of looking at these things. And it's in one of the reasons it's that way is because it's much easier to research things like that. So and I'm not knocking it. I see the value of that. But what I find is that when I teach doctoral students who are training to become licensed psychologists themselves, they get a lot of that stuff. Like they're just inundated in these, in like CBT and ACT and all of these kind of manualized approaches, right? That are empirically based, okay? Which is itself a little bit of a, because psychodynamic approaches are also empirically based as well. And they're also empirically validated in a number of ways, but it's not really the brand, I guess. But anyway, they get these things, and these techniques, they're not that difficult to get, right? But the thing that they really struggle with, and the thing that I find is the most helpful for them, is to talk with them about how do we make meaning out of what the patient is describing, right? How do you connect with this person in a way that feels real and authentic, and have something called a moment of meeting, right? A moment where there's a connection of some kind, because those are the moments that make a difference in psychotherapy. Those are the times, I think, if you look back across your life and you think about, well, what were the moments that really impacted me and really made a difference for me? It was a moment of meeting of some kind, a moment where you were seen by someone else, or you saw someone else, and something happens there. And so in my experience, the psychoanalytic school of thought, and it's in various branches on that tree, but they're all sort of about how do we make meaning out of this suffering, right? How do we listen? How do we really listen to somebody and really sort of be curious about what they're trying to tell us? how do we listen on multiple different levels, not just, okay, what's the symptom? This is the intervention, right? And by the way, I think there's a place for that. But for me, I've always, it's just never been enough, and I've done plenty of CBT. I worked for Kaiser for a year, and I did nothing but CBT and nothing but didactic groups and all that stuff. And I just, at the end of the day, it didn't feel like I was connecting with people, and didn't feel like I was helping them in the way that I wanted to help them. And so I just always come back to psychodynamic / psychoanalytic stuff. And that's just where I feel most at home. As far as, results, so, this isn't well known, but there's actually plenty of research out there that demonstrates that not only is our psychodynamic approaches on par with sort of the more common schools of therapy, like CBT and stuff like that, but they actually surpass them according to some metrics. And one of those metrics is something called effect size. And what effect size is when you do like a meta-analytic study where you take lots of different studies and you put them all together. You need some way to say, okay, well, like for instance, to answer a broad question, is therapy helpful? Well, let's look at like 100 different studies of psychotherapy, right? And somehow we're going to try to answer the question, is therapy helpful? That's called a meta-analytic study. And the way that they do that is by looking at something called effect size, which is what is the mean difference across all these studies? What's the mean difference in terms of standard deviations, right? So on average, right, psychotherapy, any kind of psychotherapy, has a certain effect size. It results in a certain mean difference in terms of symptom improvement. And you look at that, and so an effect size of 1 would be, that's 1 standard deviation above the mean. Okay, so that's considered a significant, like a massive effect size. Anyway, the point being, when you look across all these different meta-analytic studies, what you see is that there are comparable effect sizes between psychodynamic psychotherapies and things like CBT and things like ACT and whatever else over a certain span of time. But then what you see is that for the psychodynamic and psychoanalytic therapies, that effect size continues to increase over time, even after therapy stops. And so you end up seeing like crazy effect sizes over a certain longitudinal period of time that are like 1.5 or whatever, which is just, it's a crazy strong effect. And one of the reasons that are kind of hypothesized for that is because in psychodynamic and analytic therapies, you're not just treating symptoms, right? You're sitting with someone over a period of time, and actually they're kind of internalizing a new way of thinking and a new way of relating, not just to themselves, but to other people as well. And that new way, that new capacity continues to serve them over time. And so even after treatment ends, they're still making gains. Whereas, if you just did a more circumscribed treatment for a more circumscribed issue, they might show gains while treatment is happening, but then there's a tendency for them to lose those gains over time after treatment stops. Anyway, I've got a whole presentation that I give to university students on this in psychology courses, and maybe someday I'll put that up online and you can see the research I'm talking about. But anyway, thank you so much for the question. Okay, Noel says, how common is the comorbidity of NPD and BPD, and how does it manifest in comparison to just NPD or just BPD? I think they're often comorbid. And in fact, when I think about the collapse of the grandiose defenses in NPD, into a vulnerable experience, oftentimes I feel like that looks very, very much like BPD. And the only reason I wouldn't call it BPD necessarily is because there's a fluctuation between that kind of vulnerable, fragmenting, borderline kind of experience, and the more defended, constituted, grandiose experience. And that's something that people with BPD don't necessarily have, right? They don't necessarily have that kind of grandiose false self presentation that hides the underlying distress and fragmentation. But one way to think about this is in terms of borderline personality organization, which is different than borderline personality disorder. This is a psychoanalytic concept, but I find it just tremendously useful. And so if you think about this in terms of like a developmental progression over time, right? Very, very early in life, we would have something called a psychotic personality organization. And it's called psychotic because the person is like the main developmental task is just like dealing with reality, right? And not distorting reality every time there's distress. And so once you kind of got that down and you're like, okay, reality is reality and I can tolerate that reality doesn't always conform to my wishes and that it's frustrating sometimes. Once you have that defensive structure in place, then you kind of graduate to the next task, which is to separate the concepts of self and other, right? So what's me versus what's you? When something is happening inside of me, is it because of what you did, right? Or is it because of what I'm feeling, or right? Do my thoughts influence you? Do your thoughts influence me, etc.? And that might seem kind of like the way I just described it, it might sound kind of silly or rudimentary or something, but that's actually what people with a borderline personality organization struggle with, right? Where does the distress live? Is it in you or is it in me? Do I feel distressed because of something you did or something you thought, or because I'm distressed, did you intend for me to feel that way? Does that make you bad? If I feel bad, are you, right? So there's this confusion about what is self and what is not self. And oftentimes with people with BPD, one of the reasons why BPD is called borderline personality disorder is because it has many of the hallmarks of borderline personality organization. It's kind of like the poster child of borderline personality organization. The struggle in BPD between what is self and what is other is of central importance. The person, really has trouble with boundaries a lot of the time. They tend to, attach like really intensely. But then there can be a feeling of being kind of invaded by the other person and they don't like that. And so then they push the person away really, really strong, like really hard. But then when they do that, then they feel abandoned. And so then they pull back and then they push and they pull and they push and they pull. And that's kind of the dynamic in BPD. And there can be a lot of self-hatred that goes along with that process as well. And a lot of like pain and distress that just can't be located and kind of can't be articulated. And so that can express itself in the form of self-harm and stuff like that as well. That is a very similar experience to what is happening in a vulnerable phase or a collapse in NPD. There's the same kind of boundary confusion often. There's the same kind of really intense attachment anxiety. There's the same kind of self-hatred that can happen. The same kind of emotional disconstraint that you see in BPD as well. And the reason for that isn't necessarily because they're like comorbid disorders. It's because there's a borderline personality organization, and that's what borderline personality organization looks like. In NPD, then there is this kind of kind of almost like a splinter skill or something, like this part of the person that has been kind of created to sort of pretend, right, to give the impression of not being in that kind of distress. And we would call that the false self. And that kind of aspect of the personality, that false self aspect, tends to kind of even if there's a borderline personality organization, it tends to kind of pop up and live in a slightly higher stratus in terms of functioning, and not because what I'm trying to say here. It's like it's almost like a suit of armor or something, or that the person can kind of like they've had to adapt in this way. They can pull themselves together in this one kind of specific way, and appear both to themselves and to other people like they're self-sufficient and they're good to go. They got this, and that's what we call the false self. So I hope that helps. I also made a video on this. You can find it on my channel. I think it's called "Is It Vulnerable Narcissism or BPD?" And it goes into these dynamics in a little bit more detail. But I guess that the short answer would be yes. I feel like BPD and NPD are very close, and there's overlap in a number of ways, there tends to be a little bit of a difference in terms of the core conflict that the personality, like defensive personality structure, is organized around. For NPD, it has to do with the viability of self and self-esteem. And for BPD, it has to do with like attachment anxiety and feeling some intense ambivalence about how close versus how far others are from the self. Okay. Thanks for the question. Oh my goodness. This is a big question here. Norman says, what general advice would I give a room of people with NPD that are open to the idea of making some prescribed lifestyle changes? I guess that so it would have to do with sort of embracing vulnerability, and it would have to do with sort of a kind of a radical self-acceptance, accepting who you are exactly as you are in this moment. And that doesn't mean that like, oh, everything's great, you don't have to do. That's not necessarily what I'm talking about. I'm talking about just accepting the reality that you are as you are. You are who you are, and trying to find a way that can be okay. A metaphor that I use sometimes with patients is that, imagine a tree, right? And it's growing, and it starts having to grow around obstacles, right? Maybe there's another tree and its branches are in the way, or maybe there's whatever, there's a house, or there's has to grow around these obstacles, right? Because it's trying to get to the light, and there are things that are in the way. And so the tree takes a shape as a result of having to make those adaptations. And that's the shape of the tree, right? It wouldn't be that tree if it didn't have that shape. And the story of this tree is actually a story of adaptation, and it's a story of resilience. And it's a story of making the best with what you had available. And I think any of us would go outside and we could see a tree, and no matter how like twisted around that tree was, or how unusual the shape of that tree, we could see beauty in that tree, right? And I feel like this is the story for all living things, and yourself included. And so if you can find a way to sort of connect with yourself compassionately, to see yourself in the current state that you're in, whatever state that is, in the same way that you might see that tree, right? If you can find the sort of beauty there, I think that's 80% of the struggle. Because for people with pathological narcissism and NPD, there's so much like, no, I have to be perfect. No, it has to be this way, right? and there's so much pressure that they end up putting on themselves, whether or not they realize it. And this constant scrutiny of self, and this constant comparison of self to others, and this constant sort of, objectifying of your own being in this way, it ends up causing you to feel like you're not in life. You're not. I've heard people describe it as like not being a member of the human race in some essential way, right? I've heard it described as like, peering in through the window from like a cold, being out in the cold and looking in on like a family, like, having dinner or sitting around the fire. Like there's just this way of feeling outside the experience of being human in some essential way. And I think that has to do with this idea that you need to, the form of you, the shape of you needs to be a certain, right? Needs to fit a certain preconceived ideal. And that's just not how living things work. It's not how anything works. It's not how you work. And so beginning to understand that idea is a response actually to pressure that you felt from your caregivers when you were young, to, the feeling of not being accepted or not being seen or not being embraced or not being liked in some way. And so then you decided, okay, well, I'm gonna make myself a different shape, right? So that I can be liked and I can be good enough and I can get these things, these essentially human experiences that I seek. There's nothing aberrant about that. That's what I think anyone would do given those conditions. And so maybe it's what you did. And but being able to kind of see that for what it is, it was helpful then, right? It helped you survive. But now it's not helping you anymore. It's just causing you to feel like that person out in the street looking in through the window, longing to be a part of the community of people, the community of real people, right? That's another way that I've heard it described. So allow yourself to be real. And that means, you are as you are. It doesn't mean that you can't then take further steps toward, healing or toward actualizing in a way that feels good to you, etc. But all of that work, all of that progress has to start from a place of acceptance. And it can't be about like, well, I'm going to twist this thing until it has the right shape. It has to come from a place of, no, I am as I am. And now I'm going to try to grow. Now I'm going to try to heal. And so I guess that would be my advice. And the other piece of that is that, that work is best accomplished in the context of a relationship with someone else who can help you to have the experience of being seen and accepted, and so that you can begin to see and accept. And that's best accomplished, I think, in a therapy relationship with somebody who's able to give you that experience. So thanks for the question. Okay. Maladaptive daydreaming. This has come up before, and I don't think I've ever addressed it. Yeah. Okay. Oh, and then he goes on to say, please give me guidance. Okay. So two different things. So how do we make sense of this maladaptive daydreaming stuff? Well, I guess I would think of that in terms of two things. One would be like a kind of wish fulfillment in fantasy. And the other one would be a kind of avoidance, right? And so anytime somebody's kind of veering off in a substantial way in the direction of fantasy, I start to think about, okay, well, what is it about life that you can't deal with, you can't tolerate, right? So I would be, if I were working with you in therapy, I would be really curious about the themes of the daydream, right? So you say it's of social acceptance and respect. It's, you know, it seems like that there's something about that that is, I would imagine, in your life, you're not feeling accepted, right? You're not feeling respected. So I would want to be having some conversations with you about, well, what is respect to you, right? What is acceptance to you? And what is it about what you're getting or not getting in your life, right? Like, how does it measure up to the fantasy or not measure up to the fantasy? As far as like what you can uh, start to do about this, gosh, it's really difficult to say, just based on just this like one little snippet. My I would say, as best you can, I would try, if it's up to 10 hours of your day, then I would be wondering with you about, well, what is it that you're like, what is it about your schedule that is allowing you to engage in this kind of fantasy, right, for so many hours of the day? And I would actually be talking with you a little bit about distraction, right? About like, okay, well, what how can we fill up your time, right, so that there's more engagement, like you kind of have to engage more with the real world, with other people. There's something about having too much space where that's allowing you to kind of ruminate and to kind of engage in what are probably kind of obsessional fantasies at this point. And the more time you spend there, the less, it's kind of like an insidious cycle. The more time you spend there, the less able you feel to sort of contend with, the quote real world. And so I would be trying to figure out ways that you can spend less time there and more time in the real world. And looking at adjustments you can make to your schedule that kind of enforce that, right? So maybe it means looking at a different job, or maybe it means like whatever it means. Like I don't know anything about your life, but just be thinking along those lines. That's where I would probably start as far as like a concrete intervention goes. All right. What's the difference between the mastermind? 01 says, what's the difference between empathy, sympathy, and compassion? I see a lot of people using these words interchangeably. And if you don't have much of one, does that mean you don't have less in all three? So, okay. So empathy versus sympathy. And now this is going to be my take on this, right? I'm not Webster's, right? So I don't, or Merriam-Webster, whatever it's called now. But so this is my take on it. Empathy is feeling something as though it were you, like feeling what's happening to somebody else as though it were happening to you, right? So being able to kind of step into the shoes of somebody else and imagine, what must this be like for them? That's empathy, to my mind. And I think Kohut has a similar, Heinz Kohut has a similar definition. Sympathy is feeling for someone, right? So, gosh, I feel sorry for him or her, right? I feel sorry for that person, that they're struggling in the way that they're struggling. And that would be more of a sympathy. And then compassion, I guess, is sort of like, I imagine it's sort of like sympathy, but there's a little bit more kind of like love involved, right? Sort of like, it's not just feeling sorry for, it's sort of like, and I care about you, right? And I really care that you're experiencing this. So that would be how it comes up for me, at least. I don't know if if you have less of one, does it mean you have less of all three? Honestly, I think that there's kind of too much, in some ways, there's kind of like too much emphasis placed on like deficits or lacks in empathy in NPD. It's like all anybody talks about, and I feel like they kind of miss like the fundamental like piece aspects of the actual disorder. I mean, yeah, sometimes they express themselves in impaired empathy, but even when that happens, I feel like what you're really seeing there is attachment avoidance, which we talked about before, and just a preoccupation, right? So when you're preoccupied with something like, propping up a fragmenting experience of self, you just don't have a lot of resources there to have empathy for other people. You're preoccupied, right? And so there's a kind of egocentrism that goes along with that, where it's just like, if I'm like I've said this in another video, if I'm starving, all I think about is food. If I'm dying of thirst, all I think about is water. If I'm drowning, all I think about is getting that next breath of air. I don't have a lot of capacity to empathize with other people in that state. And NPD is a kind of drowning. It's a kind of starving. There's a way that the person is so desperately trying to hold together a viable experience of self, that they just can't see other people in that state necessarily. But I do think that it's the case that when the level of distress goes down for most people with NPD, the capacity for empathy goes up, and people, a lot of the commenters on my channel, they'll observe that phenomenon, but they kind of draw a different conclusion from it. They say, well, when he's out at the store, he's like Mr. He's great. He's nice to everybody, but then when he comes home, he's abusive to me. And I would say, well, that's because the level of distress or affect or whatever is lower when you're out at the store. The stakes are lower, versus when you're at home and you're dealing with a relationship that's probably problematic in a number of different ways, and all of the stress and pressure that somebody with NPD can feel in the context of a close interpersonal relationship, or an interpersonal relationship where the other person is trying to get close to them. There's all kinds of stuff that comes up there, and the dysregulation that goes along with this disorder sometimes will tend to show up in the context of that situation much more readily than it will in a low stakes situation like going to the store or something like that. So I really see this in a way as well, where's the energy going, right? And for people with NPD, that energy is consumed by the sort of central deficits in self, and their attempts to manage that issue, and so they don't tend to see other people when that's happening. So there you go. Okay, thanks for the question. All right, this is kind of on the same theme as before. Do I agree that with Kernberg that narcissism is a defense against borderline disorder? Not necessarily. I wouldn't say that it's a defense against like borderline issues. Really what Kernberg is, his kind of conceptualization, as I understand it, is that very early in the formation of the self, or the kind of self structure, there's just too much frustration. The baby essentially is trying to get its needs met, and not just like needs in terms of like food and stuff, shelter, but like emotional needs met. And the caregiver is not meeting those needs for whatever reason, or they're meeting them in a way that is just causing the infant to just be flooded with toxic, primitive aggression and frustration. And so there's the psyche starts to make like a little tweak to try to circumvent that flooding of primitive aggression and frustration. And what it does is it begins to merge with its own ego ideal. The ego begins to merge with its own ego ideal in order to short circuit dependency on frustrating caregivers. And that's in Kernberg's formulation, that's where that kind of grandiose, self-sufficient presentation comes from. And in his mind, the center of that is aggression. And he calls it's called primitive aggression because it belongs to a very early developmental stage. So that's not really a defense against a borderline, disorder or experience. That's a defense against dependency. Because dependency is experienced as too frustrating. So that's my understanding of Kernberg's idea there. I would say that to the extent that the sort of personality organization in NPD is at the borderline level, then the kind of false self grandiosity is an attempt to not experience that distress, not experience the fragmenting self states. Excuse me. That sort of live in a borderline personality organization, and so there's like this kind of island of like order, right, in NPD, and that would be the false self, sort of compensatory, grandiose island, right? And then when that gets flooded, or it falls apart or collapses, however you want to do the metaphor, then there can be an experience of the underlying borderline states and conflicts. So that might be what you're referring to, and if that's the case, then I would tend to agree. Thanks for the question. And just one second, I just have to cough real quick. Excuse me. A frog in my throat. Molly Ringworm asks, is it true that borderline level pathological narcs? I don't really like the term narc. I feel like that's a bit dehumanizing, but don't experience positive emotion. No, that's not true. There's positive emotion experienced. It's really it has to do with an instability in the experience of self, and so oftentimes when a person is in a vulnerable state, they are overwhelmed by by what we call introjective preoccupations, and these are just preoccupations about the goodness or viability or effectiveness of self. They just feel like they're just drowning in often negative affect, things like shame, humiliation, rage, envy, stuff like that. And so to the extent that is filling up the screen, then yeah, they're probably not experiencing a lot of positive emotions. There's a tendency toward depression in those states, and also, unfortunately, things like suicidality can tend to happen in those states as well. But it's not that they can't experience positive emotion in those states. It's just that they tend to be preoccupied by the distress that in other states, like grandiose states, they're not necessarily tuning into, right? So in the grandiose states, the distress is put away somewhere else. And so there's more room to have positive emotions in those states. But it's not like there's some, like they can't experience positive emotion. Let's see. All right. So some of these questions I feel like I've already kind of glanced on or addressed a little bit, so I'm not answering every question here. So I'm curious about this one, Mark. do I believe in switching therapists when it comes to healing, both for NPD and the survivor? So I'm wondering, what do you mean? Um, like if the therapy is ineffective, you mean, or if the person doesn't seem to understand NPD? In that case, yeah, then I might think about switching to somebody who feels like a better fit. Um, Let me know if that's not what the question is, but there's my answer. Gosh, what else? Okay, Rufus Demand. His friend is going through some stuff, but he watches my channel. Can I do a shout out for Cosmo? Sure. Shout out to Cosmo. And glad you're here supporting him. Give him some advice about dealing with self-sacrificial tendencies. I think it can be hard sometimes for people, and this is kind of like a little bit of like an oxymoron in some ways, because people would imagine, well, of course, someone with NPD or narcissism, they feel entitled to everything, right? But that's not necessarily the case. In fact, the entitlement that is expressed, it tends to have a kind of a foundation in like severe and profound ambivalence and doubt about being entitled to anything at all. And that's in fact where the kind of toxic shame that goes along with narcissism comes from, right? And so, I feel like there's often some issues around like feeling that you actually deserve things, like you actually deserve to be cared about as you are, right? And this is something I was talking about earlier when it comes to self-acceptance. Like, and the idea, like I've talked to so many people who, they say something like, well, I just, I have no idea why my wife loves me or my spouse cares about me or presumably cares about me, right? What is it about me that they could possibly love or care about? And I feel like that is just so like, it's just like a direct line from that idea. Like all I see when I hear that is like just this little kiddo, just not getting, not having the experience, not being shown that they're worth loving. And it's just like breaks my heart to think about that. And so I think there can often be some conflict around like deserving things. And I guess my advice there would be for Cosmo to ask himself or herself or themselves. I don't know what gender Cosmo identifies as, but you said him. Okay. Ask himself what that's about. Like, does he not feel that he actually deserves things? Is there conflict around that? And if so, to be curious about that, to begin to notice what contexts does this self-sacrifice occur in? What does it cost him? But also, what's the secondary gain as well? There's always a duality, right? There's always a cost and a benefit. To any coping strategy. Anything that somebody says is a cost and there's a benefit. So begin to ask himself about that and begin to feel curious about that and notice just kind of like the patterns that are involved. And that's a good first couple of steps for something like that. So thank you. All right. Let's see. I'm not sure that I understand this, but I might just be reading it wrong. When I was talking about the empathic approach to healing people with NPD or narcissistic traits, can I give a general, concrete example of what immersing them, what may, I'm not, I'm sorry, I don't understand the question. If you can maybe try to rephrase that and put it in the chat. I might be able to respond. See, Lisa Taylor Austin says, hi, Dr. Ettensohn. Hi, Lisa. For anybody who doesn't know, I did an interview with Lisa on her channel, and I highly recommend you go check it out, and go check out her channel as well. She's got some good stuff on there. So thanks for showing up, and thanks for saying hi. It's good to see you. Here we go. Okay, immersing them in that empathy they didn't get from their caregiver. Okay. Yeah. So I feel like that's just a basic stance, right? And you would be doing that in any any good therapist would be responding empathically to their patients, right? The difference with NPD is that the NPD presentation, unless it's fragmenting and vulnerable, is often there's like this defensive self-sufficiency, and so it can be so difficult to get through that, to actually see the vulnerable parts of them that are inside. In addition to that, there's often a kind of a reactivity that the person will have, where they will respond to your attempts to get close in a kind of a distancing way or in a defensive way. And that can be somewhat off-putting, especially to a therapist, who's like, whoa, okay, hey, buddy, if you don't want me to help, then I'll, like there can be like this kind of defensive way that the therapist can respond to that. And so somebody with NPD who's having those issues, they go through therapy after therapy after therapy, either feeling totally not seen by the therapist or feeling in some ways like punished or criticized or attacked by the therapist. And so one of the reasons why NPD is difficult to treat is because the dynamics can be so provocative and so it can be such a roller coaster ride for both parties, but for the therapist in particular, because they keep trying. The job is to keep trying to get close to a part of the person that is surrounded by shame and by sensitivity, to like hypersensitivity to feeling attacked or criticized, and sometimes rage. And it's protected by this sort of grandiose self-image that may or may not be grounded in any kind of reality. And so it's very challenging to find ways to connect to the authenticity of the person when you're kind of fielding all of this other stuff that's there to protect the person, right? It's there to protect the person both from being re-traumatized, but it's also there to protect them from their own internal instability in terms of self-esteem. And so, I think the empathy, it often just has to do with like just trying always to stay close to what you imagine the kind of the central vulnerabilities to be. Always trying to stay close. Like in my mind, I'm always trying to stay close to like the little kiddo in there, right? And just trying to listen to what that kiddo has to say, trying to listen for that kiddo's experience, their fears, their longings, their anger, their hurt, and looking for the ways that is being expressed indirectly or in a disguised way, or sometimes in a totally inverted way, based on the kind of configuration there. So I don't know if that's concrete enough for you, but that's kind of as good an example as I can kind of give just right off the top of my head. Thanks for the question. Let's see. Max Power wants to know, what do I get out of this? And is it personally fulfilling? Yeah. I mean, nobody like made me, nobody made me specialize in this, you know. I specialized in this because these issues, I see them as fundamentally human, and there's a kind of a tragedy that speaks to me, and because it just makes sense to me, and so yeah, I find it personally fulfilling, both to think about these things, to write about them, to produce content for public consumption about it, and then also to teach about it, and then most of all to treat this population and their loved ones. And partly it's if I'm being honest, it's because I so frequently have the experience of somebody coming in and doing, you know, a few sessions or sometimes less than one session before they're like, you know, oh my God, like I've never had anybody get it before, you know, and something about that, the experience of knowing that somebody feels found, that they feel discovered, maybe for the first time in a meaningful way in their entire life. That to me, that's a special thing to be a part of. And so, yeah, you know, thanks for the question. All right. Yeah. So DH, the problem is that we narcissists tend to look at empathic people as weak or marks that we can easily manipulate or use. Yeah, in a grandiose state, that's how I would imagine that would show up. But that's, to my mind, also based in a fundamental denial of the dependency longings that lie underneath that grandiose defense. And it can be very difficult to let somebody close enough to actually have an impact on you. And that can also be a terrifying experience as well. And so the defenses get rallied, and, you know, it becomes about, you know, not your weakness or your need, but the other person's weakness and their need. You know, that's just kind of how that defensive structure works, in my experience. So I get it. Yeah, it's hard. And I often have the experience of like trying to connect to that sort of the needful part of a patient, and I see it too many times to count. Like just the person being like, no, like that's not me, right? I fucking hate pity. I hate people feeling sorry for me, you know, right? And I, you know, sometimes I try to move too quickly in that direction, and I have to take a step back and be like, okay, you know, like I hear you, right? That felt like too much, or it felt too close, or that didn't feel so good. So we'll try again another time, you know. But that, yeah, those dynamics are very present in NPD. So thank you for articulating that piece of it. Titan, have I considered bias in working with narcissists who want to heal? How do I empathize with the sufferers of narcissism while staying empathic toward narcissists? Yeah, I mean, yeah, sure. There's a self-selection bias here, right? You know, both on my part, you know, as the clinician who is drawn to this work, and then also on the part of the patient who is capable or able to take a look at themselves and say, yeah, I want to make a change here, and self-selects for therapy. Absolutely, yeah. But you know, that being said, I also consume the research, right? I mean, I read a lot of research about NPD and a lot of literature about NPD, and it's all what I'm saying. It's some variant on what I'm saying here. you don't, it doesn't seem that way to folks who aren't in the field because they're watching, the rest of the stuff on YouTube, and so much of that is just not helpful. And they're reading articles online that are, that are pathologizing or stigmatizing or whatever, and kind of buying into this construct of NPD where it's about lack of empathy and abuse, and that's it. Those two things, those are the defining characteristics of NPD, and those are not the defining characteristics of NPD. Defining characteristics of NPD are fundamental instability of self that takes the form of core conflicts around self-esteem. Essentially, like I said last time, it's unstable, unrealistic, and so so that's a core issue, right? And then there are maladaptive coping strategies that are developed very early in life to help manage that core vulnerability. That's NPD. Sometimes it can take the form of abusive treatment of other people. By the way, it also takes the form of abusive treatment of the self as well. There's a reason why NPD is significantly correlated with suicide. This is an at-risk population, objectively speaking. And so, is there bias in terms of the population I work with? Yes, I will admit that. But go read the literature yourself, like actual, peer-reviewed literature on NPD, and see what you find. And I guarantee it's not going to be the boogeyman that YouTube has, wants you to believe it is. So thanks. Let's see. By the way, I'm going to go to 3:30 my time, so it's half past the hour, whatever time it is for you. Here's a good question, also by T-Tan. You're asking some good questions today. Thank you for these. Do you think at any point in their lives narcissists choose to become narcissists, perhaps by giving up on themselves in a way? Or do you think even high self-awareness would not be enough? I just, I don't know. I don't know if I believe in free will at the end of the day. So that might be a little bit of a wrinkle in the equation here. But let's set that philosophical issue aside for a second and just think about what it would mean for somebody to choose to become a narcissist, right? In my experience, what folks who have these issues want desperately is to feel understood and to feel seen in a way that helps them to make a kind of compassionate sense of their internal experience. One that isn't kind of being swallowed continuously by a kind of shame or a kind of like mix of envy and rage. They just want to be loved. I mean, really, like that's at its base, right? And that takes all kinds of squirrely, directions developmentally. But that's what it is at its base, in my experience. Since the kind of net result of narcissism is actually one where you feel that it is impossible to be loved because nobody can actually see who you really are on the inside. All they see is what you put out there, right? I mean, that's the kind of curse of the false self-defense, is that it gets so good at being the false self that it convinces everybody, sometimes the narcissist included, that's the real person. That's the whole person. So that's such a profound obstacle to the feeling of actually being cared about, that I don't think anybody ever chooses that or would choose that knowingly. I also don't think that it's a choice insofar as these issues go far enough back that they have their roots in pre-verbal experience. So that's before there was even a concept of self and other. Really, I mean, like a one that's presented or represented, right, in the mind. These experiences go back to the first year of life, and the self structure that's built from those experiences, and the personality structure that's built out of those experiences. We're talking like first 4, maybe 5 years of life here, and this is not something that children can choose. No aspect of this is the product of conscious choice, in my opinion. I think that people, they end up in adolescence and they begin to have these experiences then that are kind of characteristic of narcissism. And sometimes they begin to wonder, well, what is it about me? What is it about relationships that I keep having these kinds of experiences? Some of them don't. Some don't have that level of insight and just persist in the kind of grandiosity, the inflation collapse, and that's just, they go through life that way. But I don't think that it's ever a product of a conscious choice. Well, thanks for the question. What else? How can NPD trigger hypomanic episodes? Yeah. So there's different ways to think about this. The way that Kohut and others conceptualize this is in the form of horizontal and vertical splits in the personality. The vertical split is between the grandiose and the symptomatic experience of self, right? The grandiose and the vulnerable experience of self. The horizontal split is having to do with all of the kind of life energy of the self, the libidinal energy of the psyche, is accessible to the grandiose side of the split, whereas the vulnerable side is cut off from that. This is all like psychoanalytic stuff. So when somebody is in a vulnerable or a symptomatic state, there is a depressive kind of phenomenon where they just don't have access in some ways to that, the creative, vital energy that they do have access to when they're on the grandiose side of the split. Maybe that's true, maybe it's not. I don't know. That's one way of conceptualizing it. I think what ends up happening, if we take all the theory out, really, is that when somebody is in a grandiose phase of this disorder, they feel like possibilities are endless, right? I mean, there's a reason why in bipolar disorder, mania is often accompanied by grandiosity, right? It's because those two kind of go hand in hand, right? When you're euthymic, when you're just like, man, everything is good and I'm good and I can do whatever I want and this is fucking great. I'm just filled with potential, right? I mean, that's going to beget, like, that state of mind will itself beget a kind of hypomania, right? Because you just feel like, well, everything's possible. Shit, I'm going to go do it, right? And that can kind of feed on itself and sometimes turn into like an actual hypomanic episode, especially if there's already perhaps some kind of a biological predisposition to something like bipolar 2 disorder or cyclothymic, something or other, right? So whereas when the person is in a collapsed or vulnerable state, all of that possibility is foreclosed on, right? It's just like, no, none of it's possible. None of it's acceptable or accessible. The self that I was, the self that could do all of those things is lost. It's gone. And I can't get back there. And that begins to trigger a depressive experience, a depressive episode. So that's really, I think, what happens. That's what I see happening in my practice with folks. I see plenty of folks who have, I think, erroneously been diagnosed with some kind of bipolar disorder. I know Otto Kernberg talks about that as well, that he feels a lot of bipolar diagnoses, might actually be something more like, personality disorders and splitting, basically. Including NPD. So I hear plenty of folks with NPD talk about, this experience of self where they're the life of the party. They're, they just feel like there's just endless potential, and they just feel like just, peak like self experience. And the that can sort of happen in kind of such like a distilled or kind of pure form because of the splitting, right? And so all of the bad is split off and it's kept on the other side of that kind of vertical split, right? And so when they're in the grandiose state, for some people, it's like just mainlining good feelings, and there's none of the bad to muddy the water there. So thanks for the question. What else? These are some good questions today, everybody. Thank you for them. Norman wants to know if overconsumption of marijuana can lead to the development of NPD. No, I do not believe that's how it works. Like I said, these issues, they tend to be rooted in very early developmental trauma, relational trauma. Now, so that's kind of the core. That's kind of the foundation, right? And then, over time, like when the person becomes an adult or whatever, there can be different things that can kind of precipitate experiences of expansiveness or experiences of collapse, right? And, drug use can certainly be one of them, right? Or the kinds of internal states that are precipitated by, drug use, for good or ill, right? So yeah, but I don't think that that marijuana use itself could cause NPD. I don't think that's a possibility. Thank you for the question. Yeah, so Teton, about, the kind of direction that like the ICD is going, where we're looking at personality disorder as kind of not a categorical thing, but more of like a continuum or a spectrum. I think that's valid. My version of that I tend to use, it's not my version, the version of that I tend to use is, like I said, that kind of continuum, that developmental continuum from psychotic through borderline and neurotic up toward healthy personality organization. So, with it, like anytime somebody has a personality disorder, they're either at the borderline level of personality organization or the psychotic level. And there is some categorical piece there that has to do with the kind of central deficits or the core conflicts and characteristic defensive adaptations that develop around those core conflicts. And I do think that those can validly be separated out into kind of like discrete, personality styles. But I think there's always some overlap. There's always some bleeding into, from one to the other. And the main thing to be thinking about there is the borderline personality organization, or psychotic personality organization. That is the cause of all the trouble, right? Because somebody who has got a narcissistic personality style, but is like healthy, right? It, kind of at that healthy, in that healthy level of personality organization, they aren't kind of dealing with the same issues. They're not dealing with the splitting and the projecting and the distorted reality and the kind of wildly fluctuating experience of self and other people, the boundary confusion, the emotional dysregulation, and distress tolerance issues. They're not having those problems because those problems live in the borderline and the psychotic ranges of personality organization. So that's why I say in some of my videos, right, a person who has NPD, they will always have a narcissistic personality style. Issues about self-worth and self-esteem will always sit as central motivators in their behavior and their psychology. But all of the other problematic things that go along with NPD, those are about a narcissistic personality style organized at the borderline level. And if we can help the person to develop it past that borderline range and into a more kind of neurotic and eventually even healthy personality organization, then they're just we all have central conflicts and things that motivate us and things that we're afraid of and whatever else. I mean, that's what it is to be a person. The problem is when those core conflicts are surrounded by a defensive organization that causes the person to distort reality, to blur the boundary between self and other, and when it causes a kind of continual disruption in the continuity of internal experience. And by that, I mean splitting, right? Where one part of the self can't communicate to another part of the self, and experiences become siloed. And that leads to extreme, sometimes discontinuity between different self states. Okay, is there a way to learn empathy? Yeah, that's, you learn by receiving it. Really, I mean, that's where it comes from. That's how any of us learn empathy. To be empathized with, over time, you begin to internalize that experience, and it becomes a capacity that you now have, not just to empathize with yourself and understand your own self states, but also via that insight to understand the self states of other people. So we can't give what we haven't got, right? And so if there's kind of no self, or if the self is in pieces and those pieces exist in these siloed, kind of parts of the personality, and we can't get from one to the other, and they don't communicate well and whatever else, it's going to be very difficult then to empathize with other people. Not just because, as I said before, the preoccupations that come from having this kind of continually fragmenting, unstable experience of self, but also because when somebody is kind of in this siloed experience over here, right, it's going to be very difficult for them to conceptualize the self state of somebody who's experiencing something that's not inside that kind of siloed experience of self, until they flip to another silo that does correspond. And then they're like, oh yeah, no, I get that, right? But that can be crazy making to the people around them too. Yeah, so Colin from Glasgow is asking me about genetics. So, the jury's out about that, and not whether or not genetics is a part of it, because of course genetics are a part, but to what extent, uh, like how big of a part do they play? The studies that I've seen, and this is just me kind of, you know, pulling this out of my memory, right? So, but it's around 25%, and that's a pretty big proportion. Um, the way that I think about this is we all come into the world with a certain kind of temperament, right? A certain characteristic way of responding to stimulus, right? Perhaps we're hypersensitive, perhaps we're not, perhaps we are easy to soothe or difficult to soothe as babies, perhaps we're kind of, there's all kinds of different ways that we could kind of just come into the world with kind of this neurological apparatus that's primed based on our genetics to synthesize experience in a certain way. And then experience, and then like the world starts happening to us, right? Well, it's happening to us in the womb as well, but we come out and we behold the world, in a way. So that kind of genetic predisposition is acted upon by the quality of experience that we have, especially in those first few years of life when we're building a basic personality. And so some children are going to be predisposed to hypersensitivity, right? To all kinds of different experiences. So, I think that this is a valid critique that some folks have of the kind of the psychoanalytic models, right? Is that, well, it blames the mother too much, or it blames the caregivers too much. And okay, I hear that. It's not so much that I'm saying, yeah, somebody did this to you. It's more like you came into the world and you had this sort of canvas, right? And the dimensions of the canvas and the color of the canvas and how well it absorbs paint and whatever else, those are qualities of the canvas. You came into the world with it. And then experience begins to paint on this canvas, right? For children who happen to be kind of exquisitely attuned, right, to what seems to be going on inside of other people, right? So Alice Miller calls this the gifted child. And they're paired with a caregiver who's preoccupied for some reason, maybe because of their own narcissistic preoccupations or whatever. And they're just not available for the child in the way that the child needs them to be available. Then I think that can begin to get internalized in the form of this kind of caretaking false self construct. Excuse me. And the same goes for any other personality-based issue, right? Where it's like you've got the child and their genetic predispositions, and then you've got the goodness of fit that the environment presents to that child. And if there's a good match, then great. It's probably not going to be a big problem. But if it's a bad match, then there's going to be sometimes a tremendous problem. So that's kind of how I think about it. I tend to talk more just about and focus more on like, okay, there's trauma, right? And what I mean to say is not that like someone traumatized you, right? And it's not like that kind of a blaming sort of conceptualization. The trauma is the result of the bad match between what your kind of canvas is and what experience was painting on it. And so that's kind of how I conceptualize it. Trauma nonetheless, right? But it's not necessarily somebody's fault. All right, I'm gonna scan the rest of these questions real quick just to see if there's anything that I can get to quickly. So this one here, I just thank you for this, Robert. Oh, I just lost my screen. One sec. Huh. Well, okay, everybody, I'm flying blind now. For whatever reason, my monitor just cut out, and I know from experience if I try to unplug it and plug it back in, I'm going to lose the camera too. So what I want to say is thank you so much, everyone, for being here. I just so much appreciate this great community and the community involvement and all you folks showing up and asking me such great questions. So thanks so much for this. This is something I'm going to try to do, I think, on a monthly basis. And keep bringing great questions and comments. And thanks again. Okay, everybody, take care, and I'll see you next time. Bye.